All right, so now we're going to talk about lacerations, and lacerations are more likely to happen in stage 2. We can sometimes get cervical lacerations if the patient is pushing or if the fetus is being pushed down too hard by really hard contractions against the cervix. It's not fully dilated. But most of the time we're talking about lacerations, they're going to happen in stage 2. Perineal lacerations are the most common. Those are the things that we hear about the most. The perineum is the space between the vagina and the rectum. We identify or we class perineal lacerations by degree. A first degree tear is skin and superficial structures only. Sometimes those tears actually heal without any kind of sutures. A second degree tear extends through the muscle or into the muscle. Okay, so the muscle is also torn. That's going to require some repair of the muscle and then repair of the skin. A third degree tear is through the anal sphincter. A fourth degree is when the anal sphincter is completely transected, so completely into the rectum. Third and fourth degree tears are associated with a risk of fecal incontinence for life if they're not properly repaired. Usually, if the first repair has the best chance of being successful. So if a third or fourth degree tear happens, then that patient really, really needs the best person at doing those repairs to do it the first time. That's not always available. So sometimes there's not someone who really is very good at those, but that first repair has the best chance of being effective. We can also have some tears in the vaginal canal. We can have lacerations from instruments or from a really rapid birth. Sometimes they need repair. If you have a patient postpartum who's just having persistent trickling bleeding, the provider may need to go and see if there is a laceration that needs repair. We can have tears around the urethra and the clitoris. Those are usually pretty painful, but they're also usually shallow and heal very quickly. Cervical lacerations are more likely to occur in a rapid labor or if the patient is pushing before they're fully dilated, or sometimes if someone is trying to manually dilate the patient. And if a cervical laceration occurs, then there's a possibility that in future pregnancies, the cervix will dilate prematurely and they'll have incompetent cervix. So we want to avoid these. Cervical dilations don't tend to bleed as much. Cervical lacerations. Vaginal lacerations will bleed more. Cervical lacerations don't bleed very much. We can't really talk about lacerations without talking about episiotomy. One of the birth videos you've seen has a picture of episiotomy. Episiotomies are done with scissors. Don't know if many of you knew that. A lot of times we kind of picture a scalpel or a knife. They're done with scissors. An episiotomy is almost always at least a second degree cut. Episiotomies that are done in the midline are more likely to extend into the rectum. So some providers started doing episiotomies at an angle called it's called a medial lateral. So it's kind of at an angle. That's less likely to extend into the rectum, but those medial lateral episiotomies tend to be a lot more painful and they're a lot more difficult to close properly. And usually it's not quite, the tissues don't quite line up correctly during that repair. So most patients prefer midline unless it happens to extend. One other thing you need to know about episiotomy is that at one time, historically, they were done routinely on most births in the US because it was believed that it was safer for the mother's tissues and they prevented severe tears. Research has shown that they actually make those third and fourth degree tears more likely. So research has also shown that a spontaneous laceration usually heals faster and with less pain than an episiotomy. So episiotomies now, according to research, should be used for patients who, mostly for indications of fetal distress. So according to research, the episiotomy should be done for fetal indications. That's the fetus is showing signs of distress and they're close enough to delivery that an episiotomy is going to realistically speed that up. There are still quite a few providers who do them more routinely or more frequently, or if they anticipate a severe tear. So you're going to see a lot of variation in practice on when episiotomies are done. As a nurse, what you need to know is that an episiotomy is a wound. It's more likely to extend to the 3rd or 4th degree tears. And so you need to be assessing that wound for healing and assessing the patient for any potential complications. Okay, the next section is going to be about the effects of obesity in pregnancy. It's going to be pretty short. So basically it's going to be a list of the risk.